So, hi, good evening, everyone. I'm Dr. Ritesh, and I'm happy to see all of you here. And I think it's the first time we are interacting. So, I'll be sharing some of the cases of oculoplasty that I think you might get in the exam. And somebody has mentioned that Cairo exam has been postponed, right? Oman exam has been postponed. So, could you please just unmute yourself one by one and introduce yourself, and when are you appearing for the exam? So that I get to know, where who are we dealing with, and if you have any difficulties, you can ask me. So we can start with Asad Ali. Dr. Asad, are you here?
Yeah. Yes.
Yeah, hi, Dr. Asad. Where are you from, and when are you appearing for the exam?
I am living in Riyadh and I'm from Pakistan. So I was appearing in Amman today. Evening, I received the email that it's postponed.
Okay. All right. So you will be applying for the next uh, diet, right?
I don't know what they will plan.
Okay. So hi, welcome. Then we have
But we
Dr.
continue study,
Yeah,
inshallah.
yeah, sure. You don't stop studying, Ismail. बाद में बात करते हैं।
Okay.
आप उनको दे दो। Then we have Dr. Ashwati.
Sir, I'm from India and I'll be appearing for the Mumbai exam next month.
Okay. And then we have Dr. Deepti.
Sir, I'm from India and I'll also be applying, appearing in Mumbai next month.
Okay. Next month.
Yes, on November 20th and 23rd.
And Dr. Farhana.
Sir, I'm also appearing in the next Mumbai 21st.
All right. Then we have Dr. Maisa.
I'm from Sudan. I was appearing for a Amman exam, but postponed it. Till now, I don't know what I will do, but I will keep on studying, inshallah.
Yeah, sure. And Dr. Rimsha.
Yeah, I'm from India. I'm not actually appearing. I am already FRCS.
Okay.
So,
So
but
then
I yeah, I
help
have
me with
I
the.
think I've
So
forgotten.
if I make a
I've
mistake,
forgotten
then
everything. Yeah,
okay.
I just wanted to remain in touch. Thank you so
Right.
much.
Okay.
Yeah.
And Dr. Ruhi.
I am also appearing for next month in Mumbai.
Right. So what I will do is I'll share some of my cases, and it is not a oriented class because I'm not prepared as such PPTs, but I have pictures that I'll ask one of you to present, and what do you think, how to manage that case? So let me share my screen. Yeah. So can you see my screen now?
Yes.
Right. So we'll start with any one of you, maybe any volunteers for this first case. If you see this picture so this is a picture that we quite often get in the OSCE station. So what do you think this is? Can any one of you take this question? How will you manage this case? So we'll start with Dr. Ruhi, then I'll ask every one of you because we have a lot of time. Dr. Ruhi, can you explain this picture? How will you describe this picture, and how would you manage this case?
This is a clinical photograph of the left eye showing a swelling um, uh, at the lateral canthus.
Right.
it appears like a cystic swelling.
Mm-hmm.
The surrounding area looks normal, and it looks as the patient is somewhat aged because of the skin changes.
Mm-hmm.
Then the rest of the area, the periocular area looks normal, and the visible part of the anterior segment looks normal.
Right. So what is your
And there are
diagnosis?
yes, uh, mm, from this clinical picture, the most likely diagnosis would be a dermoid cyst from the location.
Okay. And how would you manage this case?
That excision of the cyst, including the capsule, total excision without rupturing, the complete removal.
Right. So, very good attempt. And I would just like to add on a few things. Whenever you see any lesion of the eyelid, because it is very common that they will ask some malignant or a benign lesion, and first thing you have to do is describe the lesion, and in your mind you have to differentiate whether this is a benign lesion or a malignant lesion, and you have to point towards your answer. You have to build upon your answer. Like, if you think this is a benign lesion, why do you think this is benign and not malignant? I mean, I'm asking you what are the signs of a malignant lesion of the eyelid?
Yeah, malignant lesion of the eyelid will have to ask about the history of the lesion, since how long it is present, and any changes over the lid, like any ulceration or a loss of lid architecture or telangiectasia over the lid, or any pigmentation which is long standing, which indicates malignancy, and absence of pain might be a sign.
Mm-hmm. Yeah, so you clearly mentioned that you have to mention in this case that there is no law. You can see lashes that are growing over the
Yes.
these lashes, they are growing over
Yes,
the
ma'am.
cyst, and this is you can see some sort of trans illumination, and there is no associated skin changes around the lesion. So this probably is a benign lesion, and this is what they are looking to hear from you, that this is a benign lesion, and you will excise and send for histopathology.
Okay.
So then somebody can take this now. Dr. Asad, can you take this one?
Yes. This is a swelling of the left upper eyelid in a middle-aged or old lady, and it is obscuring it's a large swelling involving almost whole of the lid, and it is covering the pupil of the visual axis. So what I can see in it's a reddish hyperemic lesion, and it is I can see the lashes on it. So what's else question about this one? This I
What
mean
is your
to
clinical
see.
diagnosis and how will you manage?
It looks like I have to differentiate it between my differential will be the eyelid tumor, like sebaceous sebaceous gland carcinoma, or other are the like basal cell squamous cell carcinoma, and also the benign lesions like benign lesions. Sorry, I forget I want to add another malignant like a carcinoma, and then the benign lesions like so. This is the differential, and I'd have to take the incisional biopsy, sent to the lab for the result, and then the treatment will be followed by the result.
Okay. So, if this comes out to be a squamous cell carcinoma, how would you manage this?
Excuse me, sebaceous cell or squamous cell? Anyone?
Yeah,
Anyone,
if
it
you
needs
say this is a sebaceous gland
excisional.
carcinoma. Yeah.
Yeah. So how will manage? First is the complete examination and investigations to look for the lymph nodes involvement to CT scan of the orbit to look for extension, and then plan for the excision. It's excisional biopsy with the Mohs micrographic surgery. Involve the dermatologist who, with the oculoplastic surgeon, they can excise and reconstruct. But this is a very large, and it may not be like direct, cannot be direct closure. It needs some grafting tissue. Grafting tissue should be standby for the tarsal plate and also from the interior lamina. So it's more than one third, more than half, sorry, and almost full lesion. Yeah. So it should be standby grafting tissue for the tarsal plate, like from palate or pinna, and for the interior lamella from the from this supraclavicular skin or tissues, means because it maybe need grafting after excision.
Right. So reconstruction techniques, they don't really want you to know, but it's good that you have a basic idea how to reconstruct the full thickness lid defect. I'll just share you what we did in this case. So this was the lesion. You can clearly see there is loss of lashes. There is this intrinsic vascularity, and there are some crusting lesions there. So definitely this is not a benign lesion. Now on examination, you can see there is a lymph node here. So that
Yeah,
means
yeah.
this lesion is spreading to the lymph nodes. In this case, you also have to remember you have to do a metastatic. You have to mention that you have to do a metastatic workup of this patient, which includes an ultrasound, abdomen, chest X-ray, PET CT. And this is what we did. We did a full thickness excision. And if you are suspecting a sebaceous gland carcinoma, you have to always do a MAP biopsy. Because sebaceous gland carcinoma has skip lesions. And if you miss any of the lesions in the inferior fornix or the superior fornix, this patient is going to have a relapse. You excise the lesion, you do a MAP biopsy, and you cryo the edges. Then you do a bridging flap. This they don't really want you to know, but it is good that you know how to reconstruct the upper and lower lid. This is the bridging flap. This is cutter beard stage one. The lower lid, the same procedure is used. Do upper partial conjunctival shading. These are lid shading procedures. For the upper lid, this is cutter beard, and for the lower lid, it is Hughes, modified Hughes. This is how the patient looks after stage two. The time period between stage one and stage two is 6 weeks. But just to give you
Excuse me, it was disconnected. How do you manage it with the grafting or with some cutter
these are
beard?
reconstruction techniques. For the upper lid defects, you do cutter beard, which is a lower lid shading procedure,
Yeah.
and for lower lid defects, you do a Hughes procedure. You don't have to go in detail how to do it, but you have to mention that you have to do a metastatic workup, and if you can mention a MAP biopsy and cryo to the edges, it will be a no add-on. It will really show that you are into the subject. Okay.
Okay.
So MAP biopsy, cryo, and metastatic workup is the things I want to highlight in any of the malignant lesions of the eye. Okay.
Okay.
Reconstruction techniques, they might not ask.
Sir, cryo will mention in what indication of cryo?
And every tumor that is affected as squamous cell or sebaceous or basal cell, you cryo the edges after excising. So you do a wide excision. Suppose this is the tumor. You take a 3 or 4 millimeter margin. Clinically, you can't see, but this tumor was extending superiorly up till here. We took a large margin and excised whole of this in the lateral cancers. And we cryo the margins. We do a double field cryotherapy to the margins of the tumor. And if this map biopsy comes out to be positive, say this 17 or this 11 number is positive, then you go doing stage 2 at this stage when you open up the lids, then you go back and do cryo to these areas. Wherever this biopsy is telling you that it is, you can see some dysplastic cells.
Okay.
Right?
Thank you, sir.
Sir, what about the lymph node? How
Yeah, so
was it managed?
this patient underwent PET CT and is currently following up with oncologist for the same. These metastases we don't have to deal with. This is clinical oncology, and they are starting this patient on chemotherapy. Right, so we move on to the next phase. Dr. Farhana, if you can take this one.
So sorry, we couldn't hear you in the last case. The patient is on chemotherapy, is it?
Yeah, the patient is following up with the oncologist and they have started chemotherapy.
Okay, sir. Thank you.
Anyone, Dr. Ruhi or
Um,
can you describe this clinical picture and how would you manage this case?
This is a clinical photograph of the right eye showing hyper dark colored.
Right. This is hyperpigmented lesion only, right? Lower lid. What else?
There are no hyperemic changes or any
Hello? Sorry, there is.
Yeah, Dr. Ruhi, you can continue. Dr. Farhana, you can take the next one.
Sir, so you had asked Dr. Farhana. Sorry, I heard my name.
No, no, yeah,
Okay,
you
okay.
continue, Dr. Ruhi, no problem. Dr. Farhana can take the next one.
Okay.
Sir, can I take it?
Yeah, sure. If you want to.
Yeah,
Farhana.
no problem.
This is the facial photograph of a patient's right eye showing there is a lesion involving the lower eyelid. The lesion is around 7 millimeter into 7 millimeter diameter. Its margin is rolled, raised margin, and there is pigmentary change. There is loss of lashes in the lid margin, and so this may be a case of basal cell carcinoma of the lower eyelid.
And how would you manage this case?
I can manage this by full excision along with 3 millimeter clear margin and followed by repair. As it is involving the lower eyelid, so I can manage it according to the remaining lid. If gap is as it is a if the gap is less than half, then I can close it directly, or it may need lateral cantho plus or minus canthoplasty or cantholysis. And if the gap is half to 1/3 to half, then I can do cut tangent semicircular flap, And if the gap is more than half, then I can do Hughes procedure. And also mustard cheek rotation flap.
Right. So you want to do a full thickness excision here and reconstruct this eyelid by various techniques that we have just mentioned, right?
Okay.
Okay, so just to give you a plethora of regions, first we described a benign cystic lesion, then we discussed three malignant lesions. Just to understand that the three lesions that are commonly seen around the eyelid are squamous cell carcinoma, the sebaceous gland carcinoma, and basal cell carcinoma. Squamous cell is the least common of the three. Basal cell is the most common, and sebaceous gland is the worst. It has skip metastasis. Just to give you an idea, if you are totally confused which lesion is this, if you see a lesion on the upper lid and it is not, see, this lesion is a basal cell carcinoma, but because it arises from the skin. The sebaceous gland carcinoma most commonly arises from the tarsal plate, the Meibomian glands. As there are more Meibomian glands on the upper lid, the sebaceous gland carcinoma is more common on the upper eyelid. And squamous cell carcinoma and sebaceous gland carcinoma, they have propensity to metastasize. So you have to do a metastatic workup in those cases. The basal cell carcinoma is locally infiltrative. It does not metastasize, so you can skip the metastatic workup in basal cell carcinoma. Because this lesion is only involving the skin, we did only full thickness skin graft in this patient. This is not ideal, but this is what this patient chose to agree for surgery. And the chances of recurrence are very less in basal cell carcinoma. Whereas in squamous cell, and sebaceous gland, if you do not control the margins, there is very high chance of recurrence. So saving the life is the utmost priority in any carcinoma. Just focus on how to manage and how you have to tell the metastatic workup and the biopsy that we do, the map biopsy and the lymph node status of the patient. Now moving on to the another benign lesion. Can anyone take this? Dr. Ruby, can you take this one?
This is a clinical photograph of a young man showing right eye, the upper medial, upper the medial canthus. There is a visible swelling, which is
Okay, so
there
can
are
you,
no
right.
skin changes over the swelling, and slightly it is pushing the right eyelid, and
Okay. What do you think? How will you manage?
based on the location, it is the supranasal areas. Most commonly, it would be a mucocele of the frontal sinus, which can present, or
Okay. What else could be the differential? See, the mucoceles are usually, so here is the location of the medial canthal tendon. This lesion is obviously above the medial canthal tendon and not below or just underneath the medial canthal tendon. What else can occur in this area?
it may be a dacrocystitis.
The lacrimal sac, the body of the lacrimal sac lies somewhere here.
Yeah.
And this lesion is above the lacrimal sac area.
Area, yes.
Yeah, so lacrimal sac lesions are usually here.
So I can't think of.
Okay, so this is an internal angular dermoid. So you have an external angular dermoid and an internal angular dermoid. And what you do in this lesion is excision biopsy. Okay. So
Okay,
orbital
right.
dermoids are the most common benign lesions in the orbit in adults as well as in children. Right. Moving on to the
Okay.
fifth, Dr. Ashwati, can you take this one? Describe the finding and how do you manage this patient?
This is a facial photograph of a child with apparent drooping of the right eyelid. It is covering the pupillary margin. There is no frontalis overaction. I can see a lid crease. There are some hypopigmented lesions on the face. I would like to ask the onset and the duration of the drooping, and whether there was any trauma associated with it.
Right. Okay, so if this is a congenital ptosis, would you like to operate on this child or would you like to wait?
If it is a congenital ptosis and as it is obscuring the pupillary axis, it is a severe ptosis and can lead to amblyopia. So I will like to operate. I will assess the. I will do a frontalis sling.
Okay.
I
What are
will
the
check for lag
materials?
of thunder.
This was my what I got in the exam, and the next question was what are the materials that you can use for the sling?
I can use an autologous facial lata, or I can use a silicone or a proline.
Proline and polytetrafluoroethylene also, sir.
Okay. So if you are a child that is less than 1 year of age, there are only 3 indications you would operate this child. If this child has a severe compensatory head posture, if he has severe ptosis which is obscuring the visual axis, which can lead on to the amblyopia, and if this child has severe astigmatism, these are the only 3 conditions I would operate this child. Because if you can clearly see in this child, he has a very definitive lid crease, but we cannot measure the LPS action. Doing a frontalis sling is not a good idea. Permanent frontalis sling with facial art is not a good idea because it is irreversible. So what we do in these cases is a temporary suture sling and we do a cross suture, prevent the exposure keratopathy. I'll discuss a lot of different cases of ptosis like this case. Dr. Maisa, can you take this one?
Okay.
Yeah.
Here,
So
this is
a
the
case that
photo
you
of
get in your
young
clinical exam.
female.
So you will have to do the measurements also. So how would you start? How will you proceed with this case when you see this patient sitting in the OPD?
Yes.
Yeah. So how would you proceed with this case?
I didn't hear that question. I will continue with observation or only the measurement.
So you have to start with observation and then measurement.
Yes, yes. On observation, there is the ptosis covering the pupil of the left eye. I cannot see the skin creases. There is no frontalis overaction. I cannot see the left eye looking slightly. There is inferior scleral show looking upward slightly. So I will ask about onset course duration, about dystosis, any history of trauma. for surgery. Then I will proceed for the measurement after completing seeing the pupil and extraocular movement and exclude other causes. In the measurement, I will first I will do MRD1, margin reflex distance once. It will be in minus in the left eye. Then I will put the ruler. I will elevate till the pupil reflex be present. So I will measure. Then I will measure also pupillary fissure height. It looks to be very small. Then I will do. I will measure the levator function. After that, if the levator function is poor, and this is the congenital ptosis, so a frontalis link will be the option.
If the levator function is good, then you will do frontalis link.
What?
Depending on your levator function, how will you manage this patient? If this patient has a poor levator action, then
yes, if the levator action is 4 or less, then I will do frontalis link.
and how would you counsel this patient? What are the post-operative treatments?
Before doing the before surgery, I will make I will examine the protective mechanism about the corneal sensation and any lagophthalmos or Bell's phenomena. I will examine under slit lamp for any signs of dry eye. I will elevate the left lid to see if there is ptosis of the right eye. I will counsel the patient about that. After surgery, she can have dryness and tearing, excessive tearing. She can have the right eye ptosis after surgery also. It can be under correction or overcorrection of ptosis. We need to tape the lid if there is lagophthalmos after surgery and wear protective glasses. Yes.
So very good answer. And the only thing I would say is you have to differentiate whether it's a simple congenital ptosis or you have some associations with congenital ptosis. Yes. Monoocular elevated deficiency.
Yes.
And the Marcus Ganglioma. The third thing.
Yes, I will ask.
Yeah.
I will ask her to move her jaw to see if there is Marcus Gunn jaw winking and to exclude this. And for extraocular movement and seeing the pupil, I will exclude myasthenia gravis and exclude third nerve palsy. Congenital third nerve palsy can be. Myotonic dystrophy, I will shake hand with her, but not in this age.
The point is, in any case of eyelid, you have to measure the pupil and the extraocular motility. These three go hand in hand. You can't miss any of these things before taking on to the management. So this patient was managed with the frontalis link, and you can see the lag of thalamus in the patient. And this is the third type of this case that you can get. This patient has a good LPS action, and LPS resection is the option in this case. And we can skip this part because we have a lot of the cases here. This is a very important case that I want to discuss, and this Dr. Sapna, can you just mention the clinical findings and then we can discuss this case?
Hello, sir. Good evening. This is a case of a baby where the eye is the right eye is protruded, where the mass lesion is protruding into the eye, and it would be a case of retinoblastoma or else any unilateral tumors, like which is extending into the anterior segment.
Anterior, I would not say anterior segment because this is on the orbital extension. How would you proceed with this case?
I would do the investigations. I would start with doing a B scan and also with the CT orbit for the tumors, and also I would do a MRI if there is extending into the optic nerve or anything, and then I would see the calcification is there in the tumor with the help of CT, and also I will look for the B scan. Is there any vitreous seeding or anything? As it is protruding into the anterior segment, sure, all these three will be there. So, and then I would counsel the patient. I would ask the mother whether the siblings are having the same problem, or else father and mother is having any problem with this same tumor, or if they are treated with the same tumor or anything in the past. And then I would like to assess siblings, and then I would counsel the patient. This has to be enucleated as it is extending to the anterior segment. And then also I would like to see the other eye, where it is affected or not. And then I would like to access the other eye with the B scan, CT, and MRI. And then I would proceed with the enucleation, or else if it is involving the bony orbit, then I would do the excenteration too. But yeah.
And what are the other tumors that can be associated with retinoblastoma?
Neuroblastoma, rhabdomyosarcoma.
And how will you counsel? How will you do genetic counseling for this patient?
Genetic counseling, if the any one of the parent is affected, and then I would say it is autosomal dominant, and the baby would be having a 50% chance of getting the tumor, and I would like to, and also the siblings will be having a 50% chance of having the tumor if both the parents are healthy, and there is a 1% chance of getting this tumor in the siblings.
So the commonly asked question is by the parents whether their next child will have this lesion or not. So you have to be really thorough
Yes.
with the genetic counseling, because it is a commonly asked question. And what I'll do is, because we have only 1 minute left, this is something that I want to discuss for another 10 minutes. And if you can rejoin on the same link, we can have a small discussion on retinoblastoma.
Okay, sir.